Hey, good morning. Decided to record my lecture on pulmonary tuberculosis today. So here we go. Quickly, we'll go through the background of tuberculosis, diagnosis, treatment, and we'll follow up with some cases. So mycobacteria, the aerobic non-spore forming rods with long doubling time. There are a couple different types, but only a few of them really cause disease in humans. That's leprosy, Mycobacterium avium or MAC, and then tuberculosis. So we'll start with leprosy, just more of kind of a historical background, not really a lot of imaging findings. Also called Hansen's disease. It's a granulomatous disease, affects the peripheral nerves, mucosa, the upper respiratory system, and skin. About 220,000 diagnosis cases worldwide annually, so still quite a few cases out there. A lot of people are permanently disabled from the disease. Initially, it was thought to be highly contagious, but it's actually 95% of the world's population is immune. Many countries had to establish leper colonies because they just weren't really sure how it was being spread. Most of them have closed. There are still a couple hundred cases reported annually in the US. So first question here, there is an active leper colony in the US. These are all abandoned leper colonies, as you can see in the pictures, but there is still one in Carville, Louisiana. It's staffed by nuns. Patients are not, traditionally were not allowed to leave. I don't know if they're allowed to leave today, but they still have about 10 residents at that facility. So that's leprosy. Quickly, again, no pertinent radiographic findings. Moving on to Mycobacterium avium or MAC. This does have some classic radiographic findings. One form is the right middle lobe and lingular. You see like consolidation and bronchiectasis, some tree and bud nodularity. That classic form is typically seen in older women. It was given the name Lady Windermere syndrome because of this obscure Oscar Wilde play where there was a woman in it and it was felt to be unladylike to spit or something like that in this play. So it was given that syndrome. Regardless, so it has that name, but again, the appearance is what you should be familiar with. MAC can also appear like TB, like we think of TB as upper lobe cavitary disease. So also there's kind of two main forms of MAC, or three main forms. The third form of the way that MAC can present radiographically is an acute hypersensitive pneumonitis. So diffuse or upper lobe, slightly upper lobe predominant central lobular ground glass nodules, where you're actively inhaling MAC, and that is called hot tub lung. So really wanted to move on to Mycobacterium tuberculosis as part of the main part of the talk. It's spread by airborne droplets. It can affect a lot of different areas of the body. So in a testing situation, you may see it on a spine CT or MR, and that's Pott's disease. Can infect the kidneys, the heart. So you're going to have it all over the body. So you could see it in multiple different test sections. It's important to understand the difference between primary tuberculosis and reactivation tuberculosis. So primary tuberculosis is usually a disease of children. They'll have a mild respiratory illness or really no symptoms at all. Usually won't see a doctor. They'll get better and no one really knows about it. That's kind of the most common story for primary tuberculosis in children. You're also going to have a second group of population, whether they're immunosuppressed or they live in crowded living situations like jails, chronic illnesses, homelessness, and IV drug use. Again, symptoms are going to be low-grade fevers, going to kind of look like a pneumonia. So again, we're talking about primary TB. Does not necessarily have an upper lobe predominance, just looks like a lobar pneumonia with some reactive lymphadenopathy and maybe a pleural effusion. Again, that primary disease usually resolves. Whether you were symptomatic or not, after that primary disease resolves, then you have latent TB. And that is a group of people that is quite a big group. They're not infectious at that point, but they have a positive PPD and then a normal chest x-ray. So they get a positive PPD because they get a job as an intern or medical student, and they get a chest x-ray because of the positive PPD. They have no cough, no symptoms, and then they're put into this category of having latent TB. Then after of that group of people who have latent TB, a small percent, about 10% of them, will then develop reactivation TB, and that is your upper lobe predominant cavitary lesions. There's been an increase in that with the HIV and AIDS epidemic and multi-drug resistant TB. This group is more, 90% of them are adults. And again, this is where you're kind of going to see the more classic upper lobe cavitary masses, tree and bud nodularity, which is, if you go outside today and look at a tree, you have all these little trees that are about to flower. That's tree and bud. And the appearance on CT of having all these little alveolar sacs filled with pus is what that finding has been described about. It's infectious. It's not specific, but I believe it was initially described with tuberculosis. Lymphadenopathy is actually uncommon in reactivation TB, common in primary TB. Question here, what percentage of the world population is infected with TB? 30%. So quite a few people out there with latent TB. Historically, tuberculosis, also called consumption or the white plague, not because it was only white people, but because you coughed up this mucousy white phlegm. About 14 million active infections, still over 1 million deaths annually, and the 8th leading cause of death worldwide. So worldwide, it's still quite a big problem, although not as frequent day to day here in Virginia. There's still 11 million people in the U.S. with latent TB, and again, 10% of those people will develop reactivation TB. We see about 10,000 cases annually in the U.S. Half of them are in foreign-born individuals, and again, most of these cases are reactivation of latent TB. And TB is the leading killer of patients with HIV. So that's some historical background. We'll move on to diagnosis, followed by treatment and some cases. Really a multifactorial approach to diagnosis. Symptoms-wise, patients are going to have fever, cough, weight loss, fatigue, night sweats, hemoptysis. They'll collect a sputum looking for AFB. Chest x-ray will help distinguish active versus latent. PPD is the skin test. Quantiferin gold is a lab-based test. Talk about exposure history and immune status. So starting with the PPD, which you all probably have to get every year because you work here, that can be false positive from a BCG vaccine, but that's still, per U.S. guidelines, is interpreted as latent TB. You can get a false positive from MAC, from the PPD, and you can have false negatives as well. The quantiferin gold test is a little bit better. It's a blood test. It avoids false negatives in HIV. It avoids false positives with the BCG, and with MAC, it doesn't say it's active or latent, but it's more specific for Mycobacterium tuberculosis. You don't have to come back 3 days later to get it read, and residents don't have to find me to sign their forms, which for some reason I'm always asked to do that. Just kidding. I love it. Outline, again, we're going to move on to some treatment. There's some historical treatments that are good to know about. We'll talk quickly about vaccination and then some current treatment methods. Historically, you could go see the king, and the king could heal you. There's sanatoriums where you would go outside and just lay in the sun, and the ocean mist would heal you. Thoracoplasty would be here on the upper right, where you'd remove ribs and like compress the apical lungs. Sometimes you'll see, you could see that case and they could say, what did this person have done? It would be thoracoplasty. They could paralyze your diaphragm, pneumothorax, intentional pneumothorax, lobectomies, all these things, but not very effective treatments. The BCG vaccine is Mycobacterium bovis. It's reduces the rate of getting TB by about 50%, which is not great compared to current COVID rate of vaccination. There are different countries used it differently. In the US, it was never used because of the rates of TB. In France, it was mandatory for many decades. Now it's optional. In the UK, it was, again, used for many decades, but then they realized that they had to vaccinate about 12,000 people to prevent one case. So then it was felt to be not recommended. Many endemic countries do continue to use this vaccination. For latent TB, so if you come to work here and you've never gotten a PPD test before and you get a PPD and it's positive, then you have to start talking about, and you have no symptoms, no signs of active infection, chest x-ray is normal, then again, you're going to fall into this group of latent TB and you get 9 months of INH. So question, what's the worst thing about treatment for latent TB? INH, hepatic toxicity, peripheral neuropathy, long duration, the pills taste bad, and you can't drink alcohol for 9 months. Answers all of the above. Treatment for active TB is a multi-drug. It's 3 different drugs, complicated schedule. Again, for active TB, and both treatment of Mycobacterium or both treatment of MAC, the Mycobacterium avium complex, and Mycobacterium tuberculosis, both multi-drug, complex schedules, long durations of treatments. Great. We'll move on to some cases a little more relevant to what you guys may see day to day in a testing situation. This case number 1, we probably see about 3 or 4 cases every afternoon, whether they're from student health or from wherever, and it says positive PPD. Most of them are normal, and we specifically say no evidence of active or prior tuberculosis. Because if you don't say that, if you just say no acute cardiopulmonary process, then you get a phone call and you have to addend it because they want to see those words. So remember that. This case, there is something. So a little calcified thing here and a little calcified thing here. We have to decide what do we want to say about that. And if in a patient that's immunocompetent with no symptoms, they get INH. As far as how we describe that, it's either. I don't typically go into these descriptions on a dictation, but you could be asked what these are in a testing situation. It would be a Gone lesion, would be the calcified tuberculoma, and then the Ranke complex is the 2 of these things together, which is the healed tuberculoma and ipsilateral calcified hilar lymph node. If I was reading this, I would say that there is evidence, and history was positive PPD in a 23-year-old. I would say evidence of prior tuberculosis, but no active disease or something like that. It was a little bit different. 34-year-old with cough, fever, and HIV, a cavitary lesion in the right upper lobe. CD4 count is 400. They go on to CT. What else do you want? A mask. Again, making sure if you're reading a chest x-ray like that in the ED or a CT scan that, and in this case with cough, fever, and history of HIV, I think it's pretty clear that this is active reactivation TB. You want to make sure that that the healthcare workers and that are seeing this patient are using appropriate precautions. If you have a differential of say you don't get that history, say it's a 60-year-old smoker with malaise or something like that, and you have a similar appearance, your I saw a report, it was in the last couple of years, where similar appearance, differential overnight was primary lung neoplasm. So 60-year-old smoker with malaise, and it was primary lung neoplasm versus atypical infection. Great. Nothing incorrect about that. They admitted the patient to, and which floor they admit them to oncology. So now you have someone with potentially active TB on the oncology floor without appropriate precautions, not in a negative pressure room. So you have to be careful, even if it's, make sure you say the word TB, because even if you say the word TB, you say not classic for tuberculosis, even just the word tuberculosis will make that person go and be in a negative pressure room. And sometimes that's appropriate. For the HIV population, you can have slightly different patterns based on your CD4 count. So above 200, you're going to have the more classic reactivation form, which is the upper lobe cavitary stuff. As it starts to drop, you can have a more primary pattern, which is going to look like a pneumonia. And then in people who are severely immunocompromised, less than 50 CD4 count, you can have a miliary pattern. And miliary patterns is named after millet seed, which is, it's about that big. It's scattered all over the place. Good. So what do you do if a patient has newly diagnosed HIV? So just came in, has TB, has active TB, and gets diagnosed with HIV because of this diagnosis. And they start them with antiretrovirals, and they feel a lot worse, and the imaging gets worse. So do you change the drugs? Do you change antivirals? Do you rebronch them, or do you not worry about it? The answer is don't worry about it. It's this condition called reconstitution inflammatory syndrome, where you can, once the patient's immune system is starting to come back online because of the treatment, they can actually feel worse and have worsening imaging findings. Because of that, sometimes people would advocate for starting the multi-drug treatment for tuberculosis before the antiretrovirals. Give it a couple weeks to get going. Case number 3, immunocompetent patient. Looks like we have some nodules. Maybe this one's cavitary. So we move on to CT. And we have a pretty nicely defined cavity in this little ball that's rolling around inside the cavity. And I show this just in distinction to this, where you have this thick-walled and active inflammation around it. Very different appearance. This is just an aspergilloma, so not related to tuberculosis, but just wanted to show you the fungal ball, because a lot of times in a multiple choice testing type situation, fungal balls will come up in one of the choices. So you want to be able to radiographically distinguish those. Case number 4, upper lobe, looks like pneumonia. Maybe there's some lucency to it. So then the question is this active or prior tuberculosis? And the answer is, well, I don't know because I don't have any priors. So you need the priors. So you get one from 6 months priors, and it looks more. So then if this is tuberculosis, this would be active tuberculosis. So you want to be careful about reading a single chest X-ray and seeing something in the upper lobe and saying, oh, this is their old TB, no big deal. Just you have to think about, do you want to be sitting next to them on the bus? So you really have to be able to distinguish between active and prior disease. You really need you need some clinical history, but also you need the priors. This is another case. This was 5 o'clock on a Friday. See this right upper lobe fibrocavitary stuff with volume loss, pleural thickening. This was someone who was in a correctional facility here nearby. Not great. It was hard to get in touch with somebody, but looks like tuberculosis, certainly concerning for tuberculosis, could be active, don't know. Case number 6. It's a case where this was read as the concern was for a cavitary pneumonia. In this case, this kind of bubbly, frothy stuff that's melting away has one should show you this because it does have an appearance that should make you think about something else. And that is a pulmonary infarct. You can see this person has a PE. So this is not an infection. This is just a pulmonary infarct that's cavitating. So keep that in the differential. Case number 7, 76-year-old with cough, weight loss, but no fever, has what looks like a cavitary lesion left mid-lung there. So, okay, it's in the left upper lobe, cavitary lesion. Without infectious symptoms, this is going to be one where both atypical infections and neoplasm are going to be included in the differential. It's important to know if to give a heads up to the team when ordering it. So make sure the procedure team takes appropriate precautions. This was biopsied and turned out to be a poorly differentiated non-small cell lung cancer. HIV patient, case number 8, CD4 count of 8. That's not good. Left upper lobe cavitary. So, all right, so we have this cavitary lesion, but looks like have some active disease here on the right as well. So not just that fungal ball that's benign. This is something that's active. We included reactivation TB in the differential. Patient was put on isolation precautions, got sputum for a bronch and a PPD. BAL was positive for MAC and negative for TB. So again, we classically think about mycobacterial disease, mycobacterial avium complex, so the MAC, as the middle lobe and lingular bronchiectasis and consolidation, but it can also look like what we think about Mycobacterium tuberculosis with upper lobe cavitary disease. Good to remember. So this is case number 9. Patient had all these gross necrotic lymph nodes in their neck, red, appropriately. The patient, based on the read of the neck, was taken to the OR for a washout of these neck abscesses through mixed flora. And then 6 months later, patient came back and had this chest x-ray where they didn't have these cavitary lesions in the upper lobes prior. Patient had an AFB positive sputum, so they started multi-drug treatment, but then it later, thankfully, speciated as MAC. So they were able to stop that and treat it differently. I can't remember, but it was a big scare for the primary team who was in the OR, potentially exposing all these people to tuberculosis. So I think in hindsight, if you saw those necrotic lymph nodes in the neck, you could think about TB. Scrofula is the classical term for that, for this necrotic tuberculous lymphadenitis. Case number 10, 13-year-old with low-grade fever, malaise, recently emigrated, some right paratracheal lymphadenopathy, some airspace disease. So this is primary TB. So primary TB in a child, lymphadenopathy, pneumonia, and lymphadenopathy. Case number 11, like a left upper lobe. Looks like a left upper lobe pneumonia. Looks like a left upper lobe pneumonia. Don't know if I would have said anything too exciting about that. When you look into the, cough and fever, pneumonia, whatever. So, you think about what else. You look on the problem list, you also see the patient has rheumatoid arthritis. One of the other things you want to think about in this patient population is as they start taking all these immune modulatory drugs and you can hear it on the news when they run all these commercials, say, can cause reactivation tuberculosis. So as the populations of people that are on immune modulatory drugs, just remember that it's going to put them at risk for reactivation tuberculosis. And it would be helpful to people treating them to know that might not just be a run-of-the-mill bacterial pneumonia. This was a case, I think it's the last case. 12-year-old recently emigrated from, a 20-year-old with cough, recently emigrated from India, looks terrible, got the CT, has a bunch of bronchopleural fistulas, which we don't often see, but just terrible. I love this report. Dr. David Clopton is one of our former chief residents. I was reading this in the morning. It was an overnight case. And you have to know David to appreciate his colorful description of destroyed appearing lung. I edited that. I can't remember if I edited it or left it in, but I sent him an email and I said, thanks for being so colorful about the destroyed lung, but I cleaned it up a bit. And then he just replied with this article. He didn't say anything else. Of the use of destroyed appearing lung, and that was Clopton's way. He was great, funny guy. That's it. Please feel free to email me any questions or find me in the hallway here today. And always looking for feedback on this format versus traditional ones. Thanks.